afternoon, everybody. I am Jana Broughton. I am a Quality Improvement Advisor with Superior Health Quality Alliance. And joining me today are Jessica Henkel, Amy Kaiser-Magner, and Patty Leonard, who are all also Quality Improvement Advisors with Superior Health. And today we're going to talk about F881 antibiotic stewardship. So we will drop in the link in the chat to the slides, as well as take questions from you throughout the presentation today. This is meant to be interactive, not didactic. So please, if you have a question, any of us will jump into the chat. If we can't answer it via chat, we'll just interrupt and we'll do it live so that we can start a conversation. If you have questions around enhanced barrier precautions, I would ask that you wait till the very end because it's not necessarily, well, it's sort of related to antibiotic stewardship. That's why we got into this mess, but we'll take those at the end and go ahead and let us get started. So I believe these are our objectives. So Amy, I believe you are up, correct? Is it Amy or Patty that starts today?
I believe that it's me.
Jess.
I think it's Jess. Okay, I guessed wrong. Go ahead, Jessica.
So yeah, today we're going to talk about antibiotic stewardship, and we're going to go through the requirements for your antibiotic stewardship from CMS. We're going to help understand and implement an antibiotic stewardship program in your facility, employ evidence-based criteria for your antibiotic use and surveillance, and help you implement tools to evaluate the effectiveness of your program. Next slide. You can breeze, right? There you go. So one of the best discoveries of medicine was the discovery of antibiotics by Alexander Fleming in 1928. And that really changed the course of medicine to destroy or alter bacteria so that it couldn't grow. And it saved countless lives. In addition to treating infections, it can be used to prevent infections in those high-risk categories. But as many of us learned through going to the doctor early on in well, for me, it was in the 80s and 90s, you needed to get an antibiotic to get your child back into daycare or back into school. And so there was a lot of antibiotic prescribing for every condition and not necessarily for just a required condition. So this has led to some unintended consequences. With antibiotic use, we see of the 4.1 million people entering a nursing home each year, 1 in 10 of those are going to be on an antibiotic at any time. 70% of the nursing home residents will receive a course of antibiotics at least once a year, and up to 75% of those antibiotic courses have been deemed inappropriate and unnecessary. And I didn't do the math, but that's a lot of unnecessary antibiotics. So that led to increased risk of adverse drug events, drug interactions, anaphylactic reactions. We have increased risk of C. diff infections during the antibiotic and up to 12 weeks after the end of the course. Up to 90% of C. diff infections occur in individuals greater than 65, and 1 in 9 older adults with C. diff will die within 30 days of their diagnosis. So that alone is a huge risk for our long-term care population. The next risk is the colonization or development of infection-resistant or antibiotic-resistant organisms, which has led to the enhanced barrier precautions and a lot more work and questions for all of us. So different organizations have different definitions of antimicrobial stewardship. But the main idea is that we're going to treat infections when necessary with antibiotics that work best for the organism and the resident that we're treating them for. And when they're not indicated, we don't use them. You can go to the next slide. So what does antimicrobial stewardship mean for long-term care? Our state operation manual tells us it has to be a part of our infection prevention program, and then it has to include antibiotic use protocols and a system to monitor use. The intent is that we're optimizing the treatment of infections by making sure that we are giving residents who require an antibiotic an antibiotic, but that we're reducing the risk of adverse events, including the development of antibiotic-resistant infections and unnecessary and inappropriate antibiotic use. And that we develop and implement a facility-wide system to monitor the use of antibiotics. So when you begin your antibiotic stewardship program, there are core elements that need to be incorporated: your leadership commitment, your accountability, drug expertise, action, tracking, reporting, and education. And we're going to learn about those a little bit more in depth in the following slides. So with leadership, you have to develop your antibiotic stewardship program, and you need to include your medical director, your consulting pharmacist, nursing and administrative leadership, and the individual with designated responsible for infection prevention and control, so that being the infection preventionist. Action and reporting. It requires that you develop protocols that describe how the program will be implemented and how antibiotic use will be monitored. And it has to be incorporated into your overall infection prevention plan. It needs reviewed annually, and your system and reporting can include antibiotic use. This might be in the form of a report you get from your consultant pharmacist or reports you run from your electronic medical record. You'll see outcome measures related to your antibiotic use in the form of multi-drug resistant organisms and through your antibiograms. When you're monitoring, you also have to provide the feedback to your prescribers. So you're going to monitor the resident response. You're going to keep an eye out for labs and cultures that were ordered, and use the antibiotic timeout to review all of those things and communicate with the physician on how the resident is doing. The pharmacy should be involved by completing a drug regimen review where they look for appropriate indications, where they look for interactions with food and other medications that are going to help you make sure that the antibiotics are giving appropriately. We're going to be looking for antibiotic resistance as cultures come back. And we're going to use audit tools to monitor compliance with the facility protocols. When looking at residents that may need an antibiotic, we're going to want to use standardized tools to make sure that antibiotics are appropriate, such as the LOBs, the S-bars, a change of condition report, or whatever your facility policy requires. But we're going to make sure that when we do get that antibiotic order, that it's appropriate, and we include the indication, dose, and duration of treatment. You also want to make sure that when the infection is cleared, that you have a process to remove that infection diagnosis from your electronic medical record. So education requirements, at least annually, you're going to want to talk to your prescribers and nursing staff about antibiotic stewardship, your antibiotic use protocols, and your facility's antibiotic use MDRO data. Informally, you will probably communicate these things with your providers a lot more frequently and your nursing staff a lot more frequently as you find issues with audits as you're monitoring your program. You're going to make sure that you include residents and families in this education by adding information to your admission packet, displaying a commitment letter, or sharing pamphlets to educate them. There is a very robust CDC train learning network module on antibiotic stewardship that you could use to educate your providers and your in-house staff. So when we think about antibiotic stewardship, the tags that you could also get along with them would be drug regimen review. If your consultant pharmacist isn't involved with making sure that they're looking at antibiotic use with each resident each time it's started. Unnecessary medications if it's not indicated. If you don't have an antibiotic stewardship plan, you could get an infection prevention tag. If your infection preventionist isn't educated in antibiotic stewardship, they could get a deficiency for that. Resident rights, they have a right to be informed in advance about care and treatment. So that's why it's important to include resident education in your education plan. Quality of life and quality of care, those tags could result from inappropriate antibiotic use leading to an MDRO or an active C. diff infection. Antibiotics should always be care planned and taken off the care plan in a timely manner. And infection control training could be cited if you don't have a plan for training all your staff, providers, and residents and families. On this slide, you can see some resources for either developing or enhancing your antimicrobial stewardship program, or you can feel free to contact Superior Health if you need individualized support from one of the quality improvement advisors. And I will drop our information into the chat.
So the purpose of an antibiotic stewardship program regarding today's presentation is actually to promote optimal antimicrobial utilization while actually improving antibiotic use in long-term care facilities. In order to assure appropriate and quality utilization of antimicrobial agents, antibiotic stewardship policies and procedures should be designed to guide healthcare providers in the appropriate use of antibiotics. So one of the core elements that Jess was actually referring to for antibiotic stewardship is identified through the CDC in nursing homes for facilities to develop and implement at least one policy or practice to improve antibiotic use. So as an IP or an infection preventionist, it's essential that you know your facility's policies that support best practices in antibiotic use. You want to make sure that you ensure that medication safety policies are current and that they include medication regimen reviews, and they are developed to meet federal regulations which are being applied to antibiotic prescribing and usage practices within your buildings. With antimicrobial consumption being very high in long-term care, I think we can all agree that it's safe to say that it's essential we are proactive in our attempt to improve antimicrobial leadership, especially in long-term care. So an effective antibiotic stewardship program begins with a well-defined and updated policy that defines your facility's appropriate use of antimicrobials, meaning, so when we say what is an appropriate use, that means selecting the appropriate or correct medication, dose, duration, and route of administration. So antibiotic stewardship policies should be updated annually or as needed to reflect your current standard of practice. So if you're actually new to your IP role, I would encourage you to look at your facility's policies and make sure that they are current, and they need to be current, again, to the standard of practice per regulations. An effective antibiotic stewardship policy also reduces or limits antibiotic resistance. And it's important that you as an IP understand that antibiotic resistance means that a microorganism, whether it's a bacteria or it's a fungi, no longer responds to the drugs designed to destroy or eliminate them. So as we know, the misuse and overuse of antibiotics is the leading cause of the global health threat associated to multi-drug resistant organisms, especially in the long-term care facilities. An antibiotic stewardship policy also has proven to improve the efficiency of treatments. It also promotes resident safety, especially while minimizing toxicity, and reduces the emergence of antimicrobial resistance. Antibiotic stewardship policies ensure proper and safe use of antimicrobials throughout the facility for every resident. And finally, adhering to your facility's antibiotic stewardship policy will also help reduce treatment-related costs, and it does reduce your risk of being cited by a surveyor. So again, make sure you understand what your stewardship policies state. And then in addition, not only is it important to understand and know your facility's policies, it's essential that your facility is actually following procedures to your policies. So whatever you're practicing, your practices must be aligned with your current policies as well as regulations to dispensing antibiotics. So to support the adherence to your facility's antibiotic stewardship program, you want to make sure that you include, or adhere, I should say, to the 5 Ds. So if you've never heard of the 5 Ds, this is one way that you can actually adhere to that policy. So the 5 Ds of antimicrobial therapy include diagnosis, drug, dose, and duration, and de-escalation. So when we say diagnosis, you want to ask yourself, does the resident's condition require antimicrobial therapy? That's the first question you should be asking yourself. And then what drug are you using? Is the drug you're using, is this organism susceptible to the drug that's prescribed? And then the dose, what is the recommended dose? And are you actually using the right dose? The duration is what is the recommended duration of the treatment? And then de-escalation of therapy, finding the next steps for treatment. Or are there any other interventions that can be initiated besides the use of an antibiotic? Example would be a resident who has a urinary tract infection. Maybe you could include increased fluid intake. And then if you don't already, be sure your facility has implemented an antibiotic stewardship program and you are following the program. Just because you have a program developed on paper does not necessarily mean that you've been following it or you are following it. And then other procedures include adhering to clinical surveillance criteria, which can be achieved by quality improvement initiatives, auditing antibiograms, which I'll be discussing in just a few minutes. Other procedures you can use to enhance your antibiotic stewardship practices include initiating a 48 to 72-hour timeout. So if you're not actually using a timeout, timeouts are a core practice in antibiotic stewardship as they provide active assessment of an antibiotic prescription that actually occurs 48 to 72 hours after the first administration of that medication, taking into account laboratory cultures and sensitivity testing results. Response to therapy, resident condition, and facility needs, such as an outbreak. The information collected during the time of phase is meant to be used to reassess each resident's antibiotic need using the 5 Ds that I just mentioned, the diagnosis, drug, dose, duration, and de-escalation. And then completion of the antibiotic timeout is recorded in the resident's record. So if you're doing a 48 to a 72-hour timeout, make sure that that is recorded in the resident's chart. You can also follow the 4 moments of antibiotic decision-making, which I have provided the link in the slide. So the 4 moments of antibiotic decision-making are the critical time periods of antibiotic decision-making. So providers are encouraged to use the 4 moments framework for all patients receiving antibiotics and whenever the need for antibiotics is considered. If you have not already, I would encourage you to take a look at that link that I have provided. This was a decision-making developed by the Agency for Healthcare Research and Quality, or AHRQ, and and you will also find that in that link that I provided, there's also a really nice timeout tool. So if you're not actually utilizing the timeout, and if you need a tool, you can actually go in there and they do provide the information for you. You also can implement an antibiotic algorithm. So algorithms can be used to guide empiric antibiotic therapy when determining the correct antibiotic. So you want to make sure you're treating the right organism using the right dose at the right time. You can also identify antibiotic steward champions, which I'll talk about champions in just a moment. And then regular auditing helps to validate staff's competency and compliance. So make sure you understand there is a difference between competency and compliance. You also can do routine auditing, also will help to identify any gaps in care and the need to review your antibiotic stewardship program. So performing regular audits also allows you the ability to provide feedback to guide changes in your practices within your facilities as well. And it also helps you identify prescribing trends. Procedures also include prescribers self-evaluating. So you could have your prescribers actually evaluating their own prescribing practices. This step is one of the most important for antibiotic stewardship. So if your prescribers are not actually doing a self-assessment, that would be an area that I would definitely highly recommend to you. So clinicians can, clinicians can and should be playing an extremely important role in performing self-assessments to develop feedback from their peers. And then self-assessments can be performed by reviewing individual reports on antibiotic use and noting continued improvement. You could also initiate infection modules for antibiotic guidance, such as UTI models. So there are a lot of different models out there for infection control guidance. So I would encourage you to look at those and then integrate quality improvement initiatives when an area of improvement is identified. So in order to have a successful antibiotic stewardship program, you must include your key stakeholders and understand the role that they play in your facility's antibiotic stewardship program. And some of those key stakeholders would be like your medical directors. So your medical directors set standards for antibiotic prescribing practices for all healthcare providers that prescribe antibiotics. They oversee adherence to your prescribing practices, as well as they review antibiotic use data and ensure best practices. So they're making sure that the right drug is being used for the right dose, the right amount of time, and being followed. Your director of nursing and IP, you have an important role in your stewardship program. You establish the standards for nursing staff to assess, monitor, and communicate those changes in a resident's condition that could impact the need for antibiotics. They use their influence as nurse leaders to help ensure antibiotics are prescribed only when appropriate. And then in addition, they can actually educate your frontline nursing staff about the importance of antibiotic stewardship and explain the policies in place to improve antibiotic use. So therefore, your antibiotic policies are just not the responsibility of the infection preventionist. They're also the responsibility of your leadership of nursing. So director of nursing, your administrator, assistant director of nursing, you all should have a clear understanding of what those policies are. One question that we often ask when we're doing an ICAR assessment with our facilities is if they provide education to their nursing staff regarding antibiotic stewardship, especially in the past 12 months. And it's a common trend that we often hear that most facilities do not. So if you're not providing education to your nursing staff about antibiotic stewardship, I would encourage you to incorporate that into your education. And you might want to see if that's also part of that policy and part of your stewardship program. Other key stakeholders are your consulting pharmacists. So your consulting pharmacists can also provide education to your staff about the different types of antibiotics and their use. They should also be reviewing antibiotic prescriptions as part of the drug regimen and review for new medications and ensure they are ordered appropriately. Your pharmacist can also establish laboratory testing protocols to monitor for adverse events and drug interactions related to use of antibiotics and other high-risk medications. Your pharmacist should be reviewing microbiology culture results and providing feedback to your prescribers. And if they're not, you need to be asking why they're not doing that, and you need to make sure that they are doing so. And then additional contributing factors to a successful antibiotic stewardship program include education. I can't stress this enough. Education is key for infection prevention, antibiotic stewardship implementation, and early sepsis detection. So your frontline nursing staff are critical in building a team working to improve communication and implementing any quality improvement initiatives. So your nurses and your prescribers should participate in continuing education and quality improvement activities to track and improve antibiotic prescribing. Your antibiotic stewardship education and training should be provided on hire, annually, and as needed. And again, if you're not providing the education, my question to you would be, why is the education not being provided? And so you want to make sure that you are adhering to, again, your policies. As an IP, you should be providing routine ongoing education training to all nursing staff. In addition, providing education to staff is a necessity. Providing ongoing education to residents and their families. So in addition to providing education about antibiotic usage to just your nursing staff, you might want to make sure you're including your residents and families into the education component. It's important to set expectations as well as address any concerns about antibiotic prescribing. So you might want to make sure you start your conversations early with residents and their families. And remember, communication and education is the key for a successful antibiotic stewardship. And if you're not speaking to residents and their families, it's important that you incorporate that into part of your practice. Additional procedures for optimal antibiotic stewardship requires prescribers to document in the resident's medical record during the order entry process indicating the use for all antibiotics. Documentation should include the indication or reason for antibiotic use, the name of the drug, dose, and duration for every antibiotics course. So as an IP, you are responsible for your antibiotic usage. I should say you're responsible for monitoring the antibiotic usage within your facility. So you want to make sure that when a antibiotic is prescribed, that you're actually looking at that documentation. Facilities should develop and provide facility-specific treatment recommendations based on national guidance and local susceptibility to assist with antibiotic decision-making for common clinical conditions. And then make sure you're reviewing your antibiotic usage within your facility. So facilities should have and adhere to a formal procedure for performing a follow-up assessment. So 2 to 3 days, so that's that 48 to 72 hour window that I talked about after a new antibiotic starts, determine whether the antibiotic is still indicated or appropriate. So a core element to antibiotic use is by taking action through your policy and practice change. So when I talk about policy and practice change, maybe your facility could implement one policy or practice to improve antibiotic use, maybe by initiating that 48 to 72 hours. So in your attempt to avoid a level 3 deficiency, remember a nursing home must develop and implement a system to monitor an actual antibiotic use. So if you're new to the IP role, that would be a question that I would highly suggest and recommend that maybe you seek out and find the answers to find out if your home is actually, what systems do you have in place currently that you're using to monitor your antibiotic use in your facility. And then as an IP, you will be responsible for monitoring both antibiotic use practices as well as the outcomes. So in order to guide practice changes in your facility and to track impact for new interventions, you're going to make sure that you want to make sure that you follow adherence to your data collection. So data collection on adherence to antibiotic prescribing policies and antibiotic use are shared with prescribers and nurses to maintain awareness, meaning when you abstract data and you identify trends in your antibiotic usage, that you're reporting the information to nurses as well as the prescribers. So you want to make sure not only are you retrieving that data, but you want to make sure that you're also tracking it. So nursing homes must be able to track and report their processes and measure antibiotic use within your facility. So an example of tracking measures of antibiotic use in the nursing home could be one process and one outcome measure. So an example of a process and outcome measure would be tracking how and why antibiotics are being prescribed, and then with tracking how and how often are antibiotics, tracking how and why antibiotics are being used, and then how often are they being prescribed. So that would be a recommendation that I have for you. And then regular reporting of antibiotic use to your facility's QAPI is part of your compliance to your stewardship program. So supporting the requirements of a facility's commitment to your formal procedures, you want to make sure you're having those conversations. So when I have conversations with facilities, I often ask how often are they discussing antibiotic stewardship with their QAPI. And sometimes I will hear, it's a conversation they have regularly. And sometimes I hear, maybe they briefly talk about it, but it's not in a, like they're not having in-depth conversations. So you want to make sure you're making antibiotic stewardship a priority in QAPI. And some facilities meet monthly, some meet quarterly, but it's essential that you're having those conversations and you're discussing antimicrobial therapy in your facilities, as well as reporting and making sure that diagnoses are being treated with the right medication, again, with the right dosing and the right duration of therapy. And then to understand antibiotic stewardship compliance, it's important to understand what compliance means. So compliance is often used interchangeably with competency, and they're not the same. So compliance is the act of following or adhering to guidelines, protocols, and procedures that have been set forth at a regulatory or corporate level. So demonstrating antibiotic stewardship compliance optimizes the treatment of infections while reducing the adverse events associated with antibiotic use. So your facility's antibiotic stewardship compliance can be validated through specific elements, and I have them listed here. So the first being monitoring your facility's antibiotic outcomes measure. So you want to make sure you're monitoring trends through surveillance. It's a great way to assess your antibiotic outcomes measure. First, you want to make sure you're clearly understanding your facility's antibiotic outcomes measure. You need to know what requirements need to be met to meet that measure. You need to monitor who is prescribing antibiotics in your facility. Is it your nursing home provider? Is it an outside provider? Maybe it's a prescriber that your resident was sent to the emergency room. Is there a prescriber that's in the emergency room that's often prescribing these antibiotics to your residents? Is there a dentist? So you want to make sure you're identifying, is it one specific provider in your facility, or are there any trends? You need to know why antibiotics are being prescribed, and you will also want to know what antibiotics are being prescribed. The compliance is also validated by tracking. So your facility's antibiotic usage tracking not only assists in validating compliance, but it also helps guide your practice changes. So tracking data can be obtained from your primary lab. So Jess talked about that. So your primary laboratory that you use, they should be able to provide you with a routine report that summarizes the percentage of antibiotic resistance seen in the common organisms that have been identified in specimens or cultures sent from your facility. Again, this is often reported on your antibiogram. And then your primary pharmacy or your pharmacist can also help track with the dispense and delivery of medications. They can also provide drug regimens, as I stated, and they can be providing you with facility with clinical consulting and then monthly antibiotic usage. So again, that will help you with identifying your tracking. And then your facility's physician, medical director, or prescribing licensed healthcare professional should be reviewing your courses of therapy as well for specific antibiotic and communicating those results by audits or feedback. And so when we talk about feedback includes antimicrobial route and dosing, as well as selecting an antimicrobial therapy and duration of that therapy. And then compliance can also be validated by your electronic health record system. So the interface and capability of your electronic health record system can be an asset to you. when creating a report, especially if you want to create like an antibiogram. So your EHR systems can be vary per facility. So most facilities use different systems. So usually like point click care or matrix, they can actually provide you with a report of antibiotic usage as well as infections. So make sure you know the functionality of your facility software provider. And then you can also complete a manual chart review as well. It's a little more time consuming, but you can actually pull out that data that you need to identify trends. And then compliance can be achieved through your antimicrobial stewardship program team. Now, a lot of facilities I talk to, they don't actually have an antimicrobial stewardship team or a program. So I would encourage you, if you don't, maybe that could be another initiative that you could develop. So I guess my question is, does your facility currently have an antimicrobial stewardship team that actually leads and advocates for careful and correct use of antibiotics in your facility? If not, I guess my question would be why? The antimicrobial stewardship team should be a multidisciplinary team. So if you do have a team or create a team, it should consist of pharmacists, doctors, nurses, and other healthcare professionals to provide antimicrobial medications are being used appropriately. And then the team actually works together to encourage healthcare professionals to use the right medication, again, with the right dose, right diagnosis. You also, in addition to a program team, you can have an antimicrobial stewardship champions. So champions are beneficial in facilities because your champions actually identify, they actually lead the programs. So with antimicrobial champions, or like I like to call champions, chain agents, if you don't have one, I would actually encourage you to consider appointing at least 2 champions. And so this could be a prescriber or support staff person. This could be a nurse or your medical assistant or a CNA. So these champions will be responsible for leading and maintaining stewardship initiatives. So if possible, these roles could actually become part of your person's formal job description, if that's what you wanted to do. But to effectively initiate a long-lasting change, you need champions. They're required. So if you want changes to be long and sustainable in a facility, I do encourage that you incorporate champions into a program. And so these antimicrobial stewardship champions are early adopters of the changes initiated by your team. And then they lead others to adopt new practices and are often well respected within buildings and are respected by other team members. And then they are working to drive and implement those changes and principles within the facility. And then lastly, compliance is validated through monthly and quarterly QAPI, as I talked about. So again, are you having those meaningful conversations about your antibiotic usages in your facility? And then for the key elements to take away for compliance. So in summary, you want to make sure to achieve compliance for antibiotic stewardship in your facility, that you're implementing antibiotic use protocols, along with reviewing and revising your facility's antibiotic stewardship programs protocol annually or as needed, along with initiating an antibiotic committee, and then identifying your champions. And then as I talked about in the previous slides, make sure that, if you're not using antibiograms, because I often find a lot of facilities are not using antibiograms, they are actually another approach to improving and dispensing the use of antibiotics in long-term care. So a nursing home specific antibiogram is an effective and inexpensive tool for improving appropriate antibiotic prescribing. And so an additional core element for antibiotic stewardship in nursing homes includes tracking and reporting. And so with an antibiogram, you can actually look at data from, usually we say a year, but you can look at data from about 6 months when you're collecting that data. So with antibiograms, prescribing providers use antibiograms when initiating or prescribing an antibiotic, because the historical information regarding sensitivity data that is a facility specifically allows for the prescriber to identify any changes in the resistant patterns of a microorganism to prescribe antimicrobial therapy within the facility. So an antibiogram report actually will aggregate. So when we talk about aggregate, it collects or groups related microorganisms together across all residents for a specific period. So the antibiogram also includes information regarding the susceptibility of each organism reported to various antibiotics. And so referring to an antibiogram report enables prescribing clinicians to make prompt, objective-based decisions in antibiotic therapy with surveillance. Because antibiograms actually provide information on local susceptibility patterns, and that's the key there. They identify patterns within your facility regarding microorganisms and then the resistance to antibiotics. They may help to reduce prescribing of antibiotics with high resistance. You can go to the next slide. And then the importance in utilizing antimicrobiograms is that they only provide situational awareness within your facility. So that means antibiograms should not dictate which antimicrobial that's used to treat an infection, but they can be used to guide a prescriber in selecting the best antimicrobial treatment when a CNS testing is pending. So if generated with consistent methodology, a routine over time, antibiograms can be used to track antimicrobial resistant trends within your nursing home. So antimicrobiograms actually encourage the responsible use of antibiotics in your facility. It's a good way to detect changes in antibiotic resistant patterns of microorganisms in your facility, and they can actually be inexpensive to develop and maintain. So some potential data sources you can use, again, to collect that data and to develop an antibiogram for your facility would be utilizing your primary lab or your contracted pharmacy. They can pull that data for you. And then if you're not able to obtain the required data directly from your lab or pharmacy, you can review your residence charts and you can abstract that data yourself. So abstracting culture results by hand and then creating your own antibiogram is an option. So if you do create your own antibiogram, you should record the culture information for every diagnostic culture result in the time frame of interest. And you have some records, so I often will refer facilities back to a billing or lab record if you need to pull that data, because going through all the charts can be time consuming as well. And then an antibiogram, again, is a great resource in providing guidance for antibiotic use. So on the next slide, you'll see that I gave you an example of what an antibiogram actually looks like. So it cannot be developed without specific information regarding your facility's microbial cultures. So again, you will need to access the results of the cultures concerning antibiotic susceptibility. So again, here's an example. So you will see in this example of an antibiogram, in the first column, you actually will see the organism itself. And so this one that's I use for an example that I am sharing with you is separated by gram-positive and gram-negative microorganisms. And then the second column you'll see is actually shows the number of residents. So that's the total number of residents who had that specific organism. And then the third column you will see that we have listed there actually is the percentage associated to the residents that are resistant to the microorganism itself. So I have it broken down. I don't know how well you can see that, but I did provide you the link if you wanted to refer back to that. So if you wanted to create one, you just know how to identify the information. And then the next slide I actually gave you, it's smaller. So when you have this data, you can go to the next, there you go. So once you've created an antibiogram, you're going to have to decide how do you implement and disperse the information, meaning once your antibiogram has been created, how will you provide that, present that data to your providers or to QAPI. So most facilities will print it out on smaller index cards if you choose to do that. It just kind of summarizes the information so it's not so spread out over like a spreadsheet. You can actually put them into smaller, present the data into a smaller context. And so if you wanted to print it out onto like an index card or a smaller whatever form you wanted to present your information, you could do that. So again, this is just another example of an antibiogram. And then the last slide that I have to show is actually creating your own antibiogram. So I gave you the link to that as well. So if you wanted to create your own, you could. So stating, if you have problems getting your information from your pharmacy or lab, you can create your own. So again, I just want to make sure that you do have that template if you wanted to make your own. And if you needed any assistance in creating a template or create an antibiogram, or if you would need information of getting an antibiogram, I would be more than happy to help you. Again, my email address will be at the end of this presentation. And then the last slide is some resources that I have provided to you that supports the content information that I've shared with you today.
Wow, Amy, that was great. I learned a lot even just listening from you as well. So I'm Patty Leonard, and we're going to talk for a few minutes about McGear's and Loeb's criteria, which I'm sure that you've heard about. I know McGear's is used in most of the facilities that I talk to, but I am curious, and if you would put it into chat, are you using Loeb's criteria? We can get an idea on who's been implemented that practice. Got one yes. Two McGear's, okay. Okay, looks like for the most part, McGear's is the standard. And this information that I'm going to talk about, Loeb's criteria, might be worthwhile considering for your program, especially if you're sometimes having difficulty getting some of your antibiotic orders to qualify under McGear's. Now, Loeb's criteria is used in a different manner, though. It is used for clinical decisions at the time that your resident presents with some signs and symptoms. You have a resident that maybe is not acting right, has an elevated pulse, maybe a low-grade temp, and you aren't quite sure what's going on. So there is a clinical criteria, and Jess is going to put that into the chat for us. There's a cheat sheet that has all the criteria for the different types of infections, where you can look at this criteria, and it will help you to assess the resident for a suspected infection. You take whatever information you have at that time, because early on, you might be waiting for culture results. You might not even have a chest x-ray resulted back, but you can consider the resident's history and look at what other devices are used. And at that time, the physician can make, I guess you would say, an educated decision whether or not he suspects that resident to have an infection that would benefit from an antibiotic being ordered for them. A lot of facilities have implemented both. My old building did, and we found that most usually our orders were in keeping with the Loeb's criteria for initiation of antibiotic therapy. That would not include the ones where the family insists, or, some of the things that are in chat here, maybe right now, residents that were diagnosed or had an order back from ER. But for Loeb's criteria, the difference is it's real-time evaluation of the signs and symptoms. Now, if you want to go to the next slide, Jana. Now, the McGear's criteria, that's a look back. That's a retrospective surveillance where you look at all the information you have on the infection. So they're most usually going to take your line listing, and a lot of you have software now that will do this as well. And you're going to see if the resident met the McGear's criteria, and there are links here for the McGear's as well, to see if you can count that as a true infection. Now, you may find that an antibiotic was ordered that on retrospective look back didn't meet the criteria, because McGear's has more criteria to be met to qualify to be a true infection. But the key to using your McGear's is making sure that you have all the data available. That's where if you keep your line list up to date and you have all the signs and symptoms, and as a DON filling in as an IP many times, if I found a resident that wasn't doing well or had a new infection and I reviewed the chart and just couldn't figure out why the antibiotic had been ordered, I would go talk to the nurse. And sometimes I also went and talked to the nurse's aides. They are the ones that are going to be able to tell you if there's been some mental status changes, or if there's been, urinary frequency or urgency. The nurse doesn't always know those types of things. So when you look at your McGear's, you get all your data, and then you're going to put it up against the criteria and see if the resident had enough of that criteria to qualify as a true infection. And when you read the information and the research on the development of McGear's, they make this statement that says failure to meet the criteria does not always mean that an infection was not present. Because we all know those anecdotal stories that somebody responded well to an antibiotic, or that a resident has dementia, and you just can't get a lot of those symptoms. They're incontinent, so you can't tell if they have urgency or frequency. You can't always, they don't eat well anyway. So a lot of those things you cannot determine from them that way. We can go to the next slide. I decided to include this. This is the S bar. It's a template for communicating to physicians regarding possibility of an infection. So with your S bar, you would review your residence chart and you would get the information. Your S is for situation. So why are you concerned? Why are you contacting the physician? The background would include previous histories, current diagnosis, and your assessment. And you can be pretty explicit here. What do you think's going on? I think he's got a bronchitis. I think his wound's infected. That would all be based off of the information that you provided earlier, that the wound had drainage, has a foul odor, redness around there, and tenderness. And then when you're talking next to the physician, you can make requests. You want to get a culture, you would like to start an antibiotic, whatever you think would be appropriate for that. And a lot of facilities do build this into their point-click care. I recommend it especially for new nurses that just don't know how to talk to a provider. In your smaller buildings, a lot of your providers are going to know your residents though, so you might not need to give as much background information. So you can kind of gear it to who you're going to talk to. Definitely, if you're talking to an on-call physician, this is a great way to be concise, but to have all the information that they would need. Jana, we can go on. So I included some more resources here on the lobes and McGears. The Minnesota Health Department has a great guide that will compare the two and also gives you more information on the benefits of each one and how to use them. I didn't go into depth at all with the McGears criteria. So if you're stumped or you have questions, by all means, reach out to any of us and we'd be happy to help you. So I think Jana, or I think I have the next couple slides here. Okay. So I think most likely Amy pretty much went through a lot of the auditing and reviewing, but we can go over it real quickly here. Talked about, looking at nurses' notes, when you're doing your review, your physician's orders, your physician's progress notes. And as a DON, I always reviewed nurses' notes for the ongoing monitoring of the antibiotic therapy. This kind of coincides with the 48, 72-hour timeout, but you need to know that your nurses are assessing for any side effects, adverse effects, that you're looking to see if your therapy is effective. No, I'm sorry, if it's being effective, as well as monitoring for signs and symptoms of a sepsis. So that's really key. And we don't touch on that very much in this presentation. However, that is always something that you need to be monitoring for, especially those residents who are on antibiotics. Make sure you document any additional communication with the provider. And then we talked about reviewing your criteria of antibiotic use against your lobes and McGears at the end of the month. Because if you determine that a lot of your antibiotics are not meeting McGears criteria, that's going to require taking that to QAPI and talking about it and determining if you need some more education with your providers. Is it a matter of the nurses aren't documenting correctly? But you need to get it so that most of your antibiotics should be meeting criteria when you're reviewing at the end of the month. So, are there any questions on that for us? Okay, Jana, it's all yours now.
Thank you, everybody. So I'm going to switch gears a little bit because I see a lot of questions in the chat talking about those difficult conversations and the frustration. And boy, do we hear your frustration about patients going out or residents going out to the ER and coming back with an antibiotic because the first assumption of the hospital ER doc is that it's an infection causing the change in mental status, causing the change in condition, without possibly doing a full workup outside of assuming it's or making the assumption that it's an infection. And then you get that patient or resident back and you're the one having to address and deal with the antibiotic and whether or not it's appropriate, whether it meets criteria, and whether the patient or resident truly has an infection. So One of the things for the administrators and DONs on the call, I know there's a few of you. I hope you're still on the call because I want to talk to you about starting the conversation. The FTAG regulations, as an infection preventionist, you're part of a team. And that team for responsibility of the FTAGs falls on the entire interdisciplinary team and the facility staff. And it starts with the administrator and directors of nursing as the leaders of the building and helping to guide, shape, and direct the policies and procedures and their effectiveness and how they, correspond to your resident outcomes. And when it comes to antibiotic stewardship, I know that facilities sometimes struggle with their provider following good protocols with use of antibiotics, and to that emergency room conversation, or facilities that have multiple providers and providers that pop up possibly like on calls on the weekend. And then you end up in that worst case scenario where you may have an agency or short-term nurse communicating with a short-term physician, and the immediate response is let's give them a broad spectrum antibiotic and wait until Monday when the staff get back to address what's going on with the change in conditions. So what I want to talk to you about is how you start those conversations. And I want to start first by prefacing this saying antibiotic conversations are tough because generationally, I don't know who was it. I think it was Jessica that alluded to in the 80s and 90s as a mom back in the mid 80s to early 90s. Your child got an ear infection. You took them to the PCP, and the PCCP gave them Bactrim or some other emycin for a broad spectrum for that ear infection, which probably wasn't truly an infection. It was probably a sinus related, pressure from weather change. We became a society that believes that antibiotics are the end all fix all for anything that's going wrong with our child or us as adults. So that's become ingrained, and we're having to fight those years of learning and do some unlearning about the responsibility of what happens when you use antibiotics irresponsibly or overuse them. And we end up with situations like MDROs. So the one thing, and I think we talked about this, is that on admission, I would really strongly encourage facilities to adopt a process where on admission, the resident, the responsible party, is not only given your policy, but a statement from your facility on how you handle antibiotic orders and what you do for communication. I would also do that on hire with nurses, and I would also do it blanketly with all of your providers in a formal letter from your corporation, if you're corporately owned, with corporate signatures of your VP of clinical, your VP, your clinical. Some large corporations have a medical director on staff, really signifying the strength of that statement, saying this is where we are, this is what our processes are, this is what we expect for our outcomes, this is what we expect from you as a provider in our building. And I also would really make this, like, if you've not put a lot of effort behind antibiotic stewardship, meaning you've not really brought it to the forefront for all your staff, the more knowledge that you can imbibe in all of your staff, your frontline staff, your midline staff, your nurses, your nursing assistants, your housekeepers, your dietary staff. And why is it important that you include frontline non-clinical people? They use antibiotics. They're the ones going to the physician still asking for antibiotics for their kiddos or their grandkids that have that ear or the sniffles. And by educating, you're going to have a better strength or bench strength of understanding of why we're not utilizing antibiotics unnecessarily. And partnering with hospitals or provider groups, your data, the data on antibiotic use and overuse in long-term care, is something that can tell your story. And so using your historic data, using your antibiograms, using your historic listing of infections, of true infections, and sharing that data openly with those organizations and saying, can we have a dialogue? Maybe use the health department in your local area as your intermediary. Use your pharmacy. Get them at the table together and talk about what the expectations and outcomes are. Share F881 or F882. I'm sorry, the wrong F tag on it, antibiotic stewardship. Correct me if I'm wrong, Jess and Patty, Amy, it's F882, correct?
Ron.
F881. F882 is IP. See, they all run together. So it's F881, but I would share the language about, the F tag with them so they can see it and hear it and talk about what it means for the outcomes of your residents and what happens when you get cited. hospitals live in a little different world than we do in long-term care, in that, when they get Joint Commission, they're not facing fining and loss of programming. It's not the same outcomes. You guys are apples and oranges. Your regulatory requirements are very different and have very, very impactful consequences for the outcomes in your building that can impact residents if you're having to pay big fines. So, the more that you can create education for your residents can be your big allies. I would include sharing, and I put on this slide, share the CDC antibiotic resources, get a resident council meeting set up, add some kind of infection prevention tip every single month in your newsletter for your families, educate your residents about superbugs. Let them know what enhanced barrier precautions are and why we're having to use them about superbugs, and how and why MDROs can be harmful to their outcomes. I think, education is knowledge and it's power in these situations. So here's some things just for you to consider. And if you individually, and I've got some of the names of the facilities that piped in about their ER, if you need some individual conversation or difficult conversation problem solving, please reach out. We'd be happy to work with you on that. We'd happy to be virtually at your table when you're having those conversations around the use of antibiotics. It's a real strong topic, and I think it's something that we all need to grasp our heads around to really problem solve. It's more than one person that can solve the problem. So bottom line, IPs, you guys need to have your team supporting. This needs to be, a whole team effort. DONs, administrators, you guys need to bring this to the table and really be the core strength for your IPs to make sure that this is happening for your buildings. Here's some things to consider on high-level audit thoughts. I talked about that weekend off shift. Where are your problems occurring? Is it one particular provider in the hospital? Is it one particular hospital system? Is it, a shift at the hospital? Where are you seeing that data? And then do kind of a deep dive into where those antibiotic orders are coming from. Track that and give that data back to the hospital infection preventionist as feedback. And document that you've had all that. I would recommend emails. And, keep track of your communication. Anybody want to chime in, Patty, Jessica, Amy, about that? I know it's a big topic.
It would be great, like it's a PIP for your QAPI.
Yep. And I
Realizing it's a journey, not
yes.
not a final destination.
Yeah.
So my husband says it's a marathon, not a sprint.
Yeah.
And it's like a 26-mile marathon. It's not a 5K. It's going to take a while. And, but I think it starts with you guys having that conversation with your leadership in the building to say, I think we have an issue and I'd like to work on this as a group, but I can't do it alone. And you can't do it alone. It has to be a unified front of conversations. Get your pharmacist, get your medical director at the table. If your medical director is not wanting to play or is ambivalent about it, you might want to have a critical conversation with your team about that. It's like, what do we do to change their mindset or change the position if possible, if they're not willing to come to the table, because this is a really big issue. And I will share, Superior Health, we're in the middle of things with CMS, and when you guys at the nursing homes on quality, we recently received our first bundle of facilities with sepsis. And we know that CMS is starting to utilize some of the MDS data that you guys put into your system to potentially send us referrals on diagnosis codes. And the use of antibiotics is to the forefront, obviously, because of the enhanced barrier precautions and all the focus on MDROs. This topic is not going to go away. I envision that in the next 5 years, this is going to be a very big topic that we are focused on.
2 minutes, Jana.
Okay, anybody got any questions?
I think one thing we haven't touched on is a lot of times if you get a recommendation from a pharmacist, you have them write a formal recommendation and send that to a primary care, they're more likely to listen to that and respond to that than a nurse telling them what to do, so to speak. So having that pharmacist write you a consultation note to send to the doctor. I did drop a link in the chat to our event survey. If you could fill out the event survey and let us know how we did, how we can serve you better, that would be great.
There's our emails. And there's how you continue the conversation. If you want to scan and join us on Superior Health Connect, there's the QR code. And there is our disclaimer slide. So it is part of the video. This is being recorded. The recordings will be available out on our YouTube channel, probably in 2 to 3 weeks. Thank you guys for joining us today. A lot of good information. Continue the conversation, reach out to one of us, jot us an email if you want some direct support or help. Thank you all.